Hello, my name is Caroline MacDonald and I'm a paediatric surgeon and urologist. This video has been created with the South Yorkshire and Bassetlaw ICB and is supported by the Children and Young People's Alliance. This is meant to be an informative video for doctors in the adult sector who might find themselves caring for children with an acute scrotum and haven't had training specifically in children's care. We're going to focus on history taking, examination and decision making. On long-term follow-up, 50 to 60% of children experience testicular loss after torsion. This is higher than in adults. And this is mainly because kids are slower to realise something's wrong. They then have to tell their parents, who then also take time to make a decision to take the children to hospital. Quick action is crucial. Delay to surgery is directly associated with higher rates of testicular loss. There's a critical 6 to 10 hour window for the best chance to save the testy. Delay to theatre is due to late presentation, transfer to a specialist hospital and unnecessary investigation. Only 30 to 50% of children actually present within 6 hours. We're doing what we can to improve knowledge in the community to get children to hospital faster. But orchidectomy rates double when children are transferred. So it's crucial to treat them at the first hospital they visit, even if a paediatric surgeon isn't available. And this means supporting urologists and general surgeons working on an adult rota to feel able to assess children, decision make and perform scrotal explorations in children under 16 years. We do appreciate this is no small undertaking and quite understand why people feel unconfident in assessing and decision making in children. Our regional survey found that 50% of urologists and general surgeons have had no formal training in examining children's scrotum, and we hope by this video we can address this training gap. When assessing children for torsion, it's crucial to understand the likely causes as they differ from adults. In children, the most common diagnosis is a torse testicular appendage, previously known as a hydatid of Morgagni. At the beginning of puberty, androgen stimulation of the embryological remnant of the Müllerian structures causes an increase in size of the appendage, which leads it to torse and causes an acute scrotum. The second most common finding is true torsion, at about 25%. Next is non-specific epididymoorchitis at 9%, and only 2% of our cases are bacterial epididymoorchitis. In adults, this is vastly different. 2/3 of acute scrotum cases are due to epididymoorchitis, and actually only 10% involve torsion, so that's less frequent than in children. Diagnoses like tumours, kidney stones and various types of cysts are much more uncommon in children and hopefully should be evident on history and examination. And conditions like chronic pain and Fournier's gangrene are extremely rare in children. Starting a discussion about history taking in children, it's worth noting that the assumption children will be embarrassed talking about their testicles isn't necessarily backed up by the evidence. Approach the topic as you would any other health condition. Implications and statements about embarrassment might actually lead to the young people feeling embarrassed when they didn't already. The biggest deal for the young people is worry about getting it wrong, and since they're already with you, the hardest part is likely behind them. In terms of the history, you'll be able to judge how much to talk to the young person and how much to talk to the family. I always tend to ask the young person first and get them to introduce their parents to me. Take the names and roles of the adults present. This aids in the consent process by determining if they hold guardianship, and it's now a recommended step in paediatric practice. Use the Socrates method to assess the pain. Key questions to focus on though, is the pain constant even at rest? Does it radiate to the abdomen? Has the child felt nauseous or vomited? And these signs would point to torsion. If the pain subsides at rest, it may suggest more an appendage torsion. Also ask about dysuria, fever and any other relevant past medical or surgical history, such as vesicoureteric reflux, posterior urethral valves, anorectal malformations or undescended testes. Allergies, starvation details and risk of anaesthetics should be taken as standard. And it may well be thought then the child is too complex and needs specialist tertiary care. In this setting, we'd recommend a higher grade specialist consult and don't delegate any conversations to the junior surgeon on take. For patients over 13, include questions about sexual history, alcohol and drug use. But framing these questions as standard epidemiological inquiries can help sidestep any awkwardness.
Hi, my name is Catherine Ridd and I'm a Senior Clinical Fellow at Sheffield Children's Hospital. To start with, before examining a child with scrotal pain, administer a strong dose of analgesia like paracetamol and ibuprofen. Conduct the exam in a private, comfortable space, and when possible, have a chaperone present as well as the parent. Begin with a standard general examination. You shouldn't particularly expect hemodynamic or temperature disruption, except when due to pain. Lymph node swelling is generally not seen in testicular or appendage torsion, but could occur in rare cases of mumps or viral infections. Begin the scrotal exam with a visual inspection. The child's posture and movements can offer clues. Antalgia on moving, but not at rest, might suggest an appendage torsion. During inspection, note the degree of erythema, if it is localised or covers the entire scrotum. If it extends towards the perineum, it might indicate idiopathic scrotal edema, which is more common in infants and young children. Note should be made of the child's tanner stage. Inspection will reveal a high-lying testis or a groin testis. The other thing you may see is a blue dot, which is pathognomonic for a torsed appendage testis. In most cases, a clear torsion is easy to identify with a high-riding blue testis in a red swollen hemiscrotum. If you see this, take the child directly to the operating room. You can gather plenty of information before even physically examining the child. First, test the cremasteric reflex by applying a brisk downward stroke from above the groin to the mid-thigh, observing for ipsilateral testis movement. Testicular elevation into the groin indicates a positive reflex, while lack of movement strongly suggests torsion. High riding refers to a testis located in the upper third of the scrotum or in the groin. Examination of the testis should start with the non-affected testis first, getting a feel for size, texture and epididymal lie. The bell clapper anatomy, where a testis lies horizontally rather than vertically, can often be better observed on the non-torsed side. It resembles a testis lying in a hammock. After assessing the normal testis, gently examine the affected one, using distraction techniques to maintain the child's trust. Fluid within the tunica vaginalis sac may suggest a reactive condition, possibly from torsion. In children, a new hydrocele is likely secondary to another issue, rather than being the primary condition. Ask the child to identify the tender area, specifying if it's the entire testis or a region like the upper pole. Look again for the blue dot, especially after repositioning the testis. If you can't see a blue dot but feel a specific sore upper pole cyst, you can diagnose a torsed hydatid. If the entire testis is tender to touch, assume torsion until proven otherwise. You may feel a bulky cord and possibly even a twist within it.
In cases of clear torsion, the decision is straightforward. The child needs to be scheduled for urgent surgery, and the symptoms of torsion in children are the same as in adults. The challenge really arises when the symptoms are ambiguous, but there are tools to help. Scoring systems, urine dip and imaging. The tanner stage may also help you. If the young person is tanner 0 or 5, a torsed appendage is less likely, while torsion is more probable in stages 4 and 5. The TWIST score is validated in emergency practice and in 2 surgical departments in the USA. Points are awarded for testicular swelling, hard testy, high testy, absent cremasteric reflex and nausea and vomiting. A score over 5 suggests torsion and the children should be booked for urgent surgery. A score of 0 means torsion is unlikely, but clinical acumen still needs to be made. The child most likely can be sent home with safety netting. It is of note that the scoring system only really works for children presenting within the first 24 hours of symptom onset. Outside this time, the score has less application. It really helps direct triage and prioritises those needing surgery quickly. For those with an intermediate score, urine dip and microscopy may be of use, suggesting bacterial epididymoorchitis. if positive and the history fits, send a urine sample and culture and treat. If the young person is sexually active, then this may direct your care and referral to a GUM clinic can be made. In other cases, the Doppler ultrasound by sonography or radiology experts may be appropriate. Currently, a point of care ultrasound is not validated. I'll hand over now to my colleague Gillian, who will talk to you more about ultrasound in the acute scrotum in children.
Hello, my name is Dr. Gillian Klavkowski and I'm a consultant paediatric radiologist at Sheffield Children's Hospital. Ultrasound can be useful for children and young people with an acute scrotum which is not clearly torsion. For example, ultrasound is good for assessing for complications of epididymoorchitis in the setting of trauma and assessment of suspected testicular masses. Ultrasound is also useful in confirming a clinically suspected torted testicular appendix. The subject of testicular ultrasound in the setting of torsion is complex. There are diagnostic pitfalls, clinical correlation is essential, and it should not delay timely exploration. Therefore, the following is not intended to be instructive or definitive. In some cases, ultrasound can confirm torsion, for example when there is no flow to a testicle. It may suggest torsion when there is differential flow to the testes or a spermatic whirlpool sign. The position of the testes can be assessed at ultrasound to see if the lie is abnormal. There are some grayscale features combined with colour findings that can suggest torsion. One should be aware that the Doppler ultrasound findings may be falsely reassuring in the early phase of torsion and in partial or intermittent torsion. Blood flow can be preserved in partial and intermittent torsions. Present arterial flow does not exclude torsion. It is even said that testicular vascularity can look symmetrical with the contralateral asymptomatic side with preserved arterial flow and still represent testicular torsion. The ultrasound findings of hyperemia within the epididymis and the testicle can be seen in torsion-detorsion events of the testicle, and this ultrasound appearance can mimic epididymoorchitis. So, the presence of intratesticular colour flow does not exclude testicular torsion. It is paramount that clinical evaluation is matched to the ultrasound findings in the setting of scrotal pain. Please be aware that these are general local comments and literature-based comments and are not intended as a pathway to direct practice, and that these comments are not prescriptive in this controversial setting. You should always follow your local guidelines and up-to-date data, literature and pathways.
Where torsion of testes is suspected, clinically or with a high score, national guidelines would be to suggest that children should be taken to theatre within 3 hours of the decision to operate. In this situation, ultrasound might actually delay the operation necessary, so we only really advocate ultrasound in children where clinical suspicion is low and it might reveal a torsed appendage, allowing you to take a more conservative approach. Pre-op preparation for children doesn't differ from adults in terms of marking and assessing anaesthetic risk. The only noticeable difference based on my discussions with adult colleagues is we don't usually state infertility in consent when taking a child for unilateral torsion. Long-term studies don't really show that unilateral torsion impacts on fertility. There's no specific evidence-based to approach, midline or transverse is appropriate. For those with torsion, detorsion should be undertaken and a period of assessment for reperfusion undertaken. Guidelines from Baus and Burst's Fix-It recommend using warming gauze and reassessing. There's no validated metric for deciding whether to fix or remove the testes, but leaning towards fixation is advisable. The evidence of anti-sperm antibodies doesn't really hold out in children, and if the child loses the testes, they have more time to adjust. Post-torsion infection and scrotal collection is very rare. We recommend a 3-point fixation using small PDS sutures placed outside the tunica, but followed by a dartus layer closure before the skin. Avoid using glue for skin. Follow the algorithm as outlined in the Burst Fix-It study, which advises whether to proceed with torsed or non-torsed testes treatment. Contralateral fixation is mandatory if torsion is present. Bell clapper fixation is advised for bell clapper deformity is seen. If a torsed appendage is found, it can be removed leaving the opposite side untouched. We would recommend follow-up for all children and young people with true torsion to 12 months to check for late atrophy, and also timing of testicular prosthesis can be made. If the child or young person has a clear torsed appendage testes on exam or on ultrasound, the family can be offered either a conservative or a surgical approach. We would generally recommend non-surgical due to the risks of scrotal exploration, but if the child is in excessive pain, it can be offered for analgesic purposes. We hope this video has been of help. The key resources we would recommend would be the Baus Burst Fix-It paper from 2022 and the Essential Skills paper from 2022 produced by Helen Please and Shekhar Biani. Resources for testicular torsion videos and lesson plans can be found at testicularhealth.info. And it's just worth noting that national and regional pathways are currently under development. Our take-home messages are: 1. The etiology in children and adults is different and must be kept in mind when assessing children. Epididymal orchitis is rare. 2. Ultrasound is not a blanket tool for torsion in children and may lead to harm and confusion. Preserved flow and epididymal inflammation can be seen in torsion. And 3. Follow-up should be to 12 months in true torsion to catch late atrophy. We would like to thank you for your interest and your care for children and young people with painful scrotum. So thank you.